This presentation is on the visual system, and let's begin by looking at where the visual pathway begins. Now, the entire visual pathway extends from a layer of the eyeball called the retina, and it travels out of the retina in the optic nerve. Now, when you look at the eyeball, this is a cut section of the eyeball. So when you're looking at a cut section of the eyeball, the innermost layer, that layer is the retina, which is this one. And in the retina, you have photoreceptors present, and the photoreceptors are your rods and cones. Cones are meant for color vision, and rods are meant for vision in dim light. Now, the rods are so arranged that they are present more towards the periphery of the eyeball. So they are towards the peripheral area of the eyeball, whereas the cones are concentrated in a portion of the eyeball which is called the macula lutea. So this area of the eyeball is called the macula lutea, and you can see up here, this is the area which is called the macula lutea, and in the center of that macula lutea you have a point which is known as the fovea centralis, and it is at this fovea centralis that we have the maximum number of cones, and visual acuity is maximum at that point. Now, the rods and cones, which are the photoreceptors, they make contact with a second layer of the retina, which is the layer of bipolar cells. So let's say we have, these are the rods and cones, and their axons make contact with these bipolar cells. Naturally, because it's a sense organ, you have these bipolar cells, and these bipolar cells in turn make contact with cells which are known as ganglion cells, and they're rather large. Now, the axons of the ganglion cells exit from the eyeball, and they travel as the optic nerve. So if you look at this, this is the optic nerve, and it is the ganglions of these, it's the axons of this ganglion cells which form the optic nerve. Now let's look a little bit more in detail about the eyeball, and especially this area of the optic nerve. And here what you see is that this is the optic, these are the axons which form the optic nerve. This area where the optic nerve leaves the eyeball, that area is known as the optic disc, or also called the optic papilla. At this portion, you have no photoreceptors, so you have no rods or cones, so hence, if light falls on this part, nothing will be stimulated because you have no rods or cones, so you cannot perceive color or just light in that area. So this part here is known as the blind spot. Now, this optic nerve, as it emerges and passes out, it is surrounded by the subarachnoid space, and we saw this earlier when we were doing the meninges. And this is important because if there is an increase in intracranial pressure, which we'll see in later slides, you will see that this subarachnoid space gets really large, and it compresses the optic nerve, and also compresses these blood vessels which are present in the optic nerve, known as the central artery and vein of the retina. So keep that in mind at this moment, so that when we do a condition called papilledema, you'll be looking at this. Let's move on to the next slide and look at the layers of the retina, and then see where the optic nerve is in relation to the brain. So here we have the layers of the retina. Many books give it as 8 or 10 layers. It doesn't really matter because 2 of the layers are just a thin membrane. So let's look at this where it gives you 8 layers. So the layer which is present closest to the choroid, you must have done the eyeball. So you have 3 layers in the eyeball. The outside layer or outermost layer is the sclera, and then we have the choroid, and the innermost is the retina. So the layer of the retina which is closest to the choroid, that layer is called the pigmented cell layer, which is this one. It has a lot of melanin pigment here, because when light strikes the retina, it passes through all these layers and comes and hits this pigmented layer, and then gets reflected back and causes a reaction in all these cells. Now, excess light is absorbed by that pigment, and that helps to protect the retina. The second layer is this layer of rods and cones, and then we have, you have various synapses and so on. Then we have a layer of bipolar cells, and then this one is the layer of the ganglion cells, and you can see how they all form synapses with each other. Now this layer of pigment develops separately, and all the other layers, they develop separately. So actually there is a potential space present between this first layer and the other layers, and this space can get larger when the retina separates. So imagine there's a little bleeding in this space, then we get what is known as retinal detachment. So retinal detachment is actually not separation of the retina from the choroid, but it's really separation of the retinal layers themselves. So the first layer separates from the other layers which are together. Now if this becomes large, then what happens is that the rods and cones, they do not get any nutrition, because this pigment here, this pigmented layer, also provides nutrition to the rods and cones. So if the connection between them goes, then the rods and cones do not get any nutrition, and so the person can go blind. So anyway, so coming back to these ganglion cells, as you can see here, these ganglion cells, their axons form the optic nerve. So when light strikes, what it does is it actually passes through all the layers of the retina and hits this pigmented layer. Excess light is absorbed, and then that light sets about a reaction in these photoreceptors, and then that stimulus passes back this way, so it travels all the way out and then comes out in the optic nerve. So you can see how the light actually has to go past the retina, hit the pigmented layer, and then set off a reaction and travel this way. Now this optic nerve which is formed, as it comes out of the brain, you have an optic nerve on either side. It passes through the optic canal, and then the optic nerve, the two optic nerves join together in an area which is known as the optic chiasma. This chiasma then travels laterally to form the optic tract. So this area here is the optic tract. We will see this tract later. This tract travels all the way this way and leads into the occipital cortex, which is above this cerebellum, which is the area where vision is perceived. Now in close relation to this optic chiasma, in this area, this is where the pituitary gland lies. So if there's a tumor of the pituitary gland, you can see how a huge tumor can involve this optic chiasma. So that's why whenever there are any visual problems, we suspect either there is trauma in this area, there could be possibly tumors, and particularly pituitary tumors which could affect the chiasma, or there could be demyelinating diseases. You have heard of one that we discussed earlier, multiple sclerosis. So it destroys the myelin. As this optic nerve comes out, then it gets myelinated, so it can destroy the myelin, and then these people again suffer from small patchy areas of blindness. And of course any vascular lesion can involve this optic nerve or the optic tract. Let's move on to the next slide. And here we are looking at the visual pathway. Now one thing to remember about the visual pathway is that it isn't as if the right optic nerve carries fibers to the left occipital cortex. It is the field of vision which is represented in the occipital cortex, which is the visual cortex. So if you have the right field of vision, that goes to the left occipital cortex, and the left field of vision is represented in the right occipital cortex. And let's see how this visual pathway actually travels. So here we are looking at an object over here. So this is the left occipital cortex, and this is the right occipital cortex. Similarly, let's divide this field of vision into a left and a right, and here again we have left and right. Now just follow my pen, and if you notice, the left, everything in the visual pathway is kind of opposite. The left field of vision, light from the left field of vision will strike the right half of the retina, and light from the right field of vision will strike the left half of the retina. So if you look here from the left field of vision, you can see that light is striking the right half of the retina. From the right field of vision, light is striking the left half of the retina. Here again, light from the right field of vision is striking the left half of the retina, because this is the left side of the retina here for this eye, and from the left it's striking the right half of the retina. Now when the light rays strike that half of the retina, then it stimulates the pigment layer, and then the synapse occurs between that and the that goes on to stimulate the rods and cones, which then synapses with the bipolar cells, and that whole sequence starts. Now once the ganglion cells are stimulated and the fibers come out, then what you will see is that fibers from this left half of the retina travel in the optic nerve. They remain on this side and they travel to the occipital cortex on the same side. So let's keep it on this side. Fibers which strike the right half of the retina, they cross, as you can see, they cross in the optic chiasma, and they go to a part here which we'll come to. So they're traveling towards the right occipital cortex. But I said the right half of the retina travels to the right occipital cortex. But what is the right half of the retina getting impulses from, or which area of, or which field of vision is it getting its impulses from? From the left. So you can see, so the left field of vision travels ultimately to the right occipital cortex. Let's look at the eye on this side. Again, the right field of vision, it has stimulated the left half of the retina, and once it has stimulated the left half of the retina, the fibers come in this part of the optic nerve. They cross over in the chiasma and they travel again to the left occipital cortex. So you can see the left occipital cortex gets the right field of vision from this side, and here again, if you look, it's getting the right field of vision from this side. So you see how the right field of vision is represented in the left occipital cortex. Here for this side, see the left field of vision, the light from there strikes the right half of the retina. It travels on this side of the optic nerve, on the lateral side, remains on the same side, and then goes to the right occipital cortex. But so the right occipital cortex is looking at the left field of vision. Now just in case some of you have not understood this, I'm going to draw it again for you. So here's the eyeball. And the eyeball of this side. And we'll just keep it on this part. So this is the left cortex and this is the right cortex. Now here, let me just draw a line to represent the field of vision. Like this. So we can say that about up to this point. So this side is the left field of vision and this side is the right field of vision. So from this left field, it strikes the right half of the retina. Again, from the left field, it strikes the right half of the retina. This has struck the right half of the retina. It travels in the medial part of this optic nerve and comes on in this optic tract. So it goes to the right cortex. So again, from the left side, it strikes the right half of the retina. Now it remains on the lateral side of the optic nerve on this side, travels in it and goes to the right cortex. So can you see that the left field of vision has gone into the right occipital cortex. Now let's look at the field of vision from the right side. So from the right side, crosses in space, as you can see here, strikes the left half of the retina, travels in the optic nerve. When it's present laterally, it doesn't cross over, so you can see only the medial fibers cross, and you can see now this is going to the left occipital cortex. Again, from the right field of vision, strikes the left half of the retina. Now because it's on the medial side, it travels on the medial part of the optic nerve, crosses over in the chiasma, and goes over to the left cortex. So can you see that the right field of vision is represented in the left occipital cortex? So this should explain to you how the crossing has occurred. And you can see half of the crossing occurs in space up here, and the other half of the crossing, can you see, occurs within the optic chiasma. So only half of the fibers cross here because the other half have already crossed in space. And now let's follow the visual pathway as is given in your notes, and you can see how we have the fibers in the optic chiasma crossing. So the fibers would have crossed in the optic chiasma. The fibers which remain on the lateral side remain on the same side. Now this forms the optic tract. So this area here is the optic tract. Now in the optic tract, once it is formed and it is nearing the midbrain and the thalamus, it divides into a medial root and a lateral root. So this part here is the medial root, and you can see it's a very small part, and this area here is the lateral root. The rest of it, most of it, is the lateral root. The medial root consists of 10% of fibers, so very few fibers which leave this optic tract, and they go to the midbrain and the superior colliculus in the midbrain, or a part of the thalamus here, or a pretectal nucleus which is lying in front of the superior colliculus, and these fibers are involved in pupillary reflexes. Most of the fibers, which is 90% of the fibers, they go and synapse in the lateral geniculate body. And if you remember, the lateral geniculate body was associated with the thalamus, and this is involved in the visual pathway, just like the medial geniculate body was involved in the auditory pathway. So once they synapse in the lateral geniculate body, the fibers, neurons begin from, a fresh set of neurons begin from there, and they go to the occipital lobe, and in the occipital lobe you had a sulcus which was called the calcarine sulcus. So they go in and synapse mainly in the calcarine sulcus, and some of the fibers spill over on the medial side. So all of this area is called the primary visual cortex, and which is area 17 according to the Brodmann's area. It's labeled area 17. You'll do a little bit about these Brodmann's area when we do the cerebral cortex. Now surrounding this visual cortex you have other areas which lie close by. Fibers go to those areas which are, say, here and here, and those are known as visual association areas. And what they do is they are important for recognizing objects and for perception of color. So that's known as the visual association area. Now this figure that you're looking at next to it looks very confusing in the beginning, but all I want you to understand from this figure is that, one, if you remember, I told you that everything in the visual pathway is kind of upside down. As you can see, the left field goes to the right half of the retina and the right occipital cortex. So similarly, the upper field of vision travels to the lower part of the cortex. The middle of your field of vision goes to the posterior most part of the occipital cortex, and that's really what this is representing. See here, this is the upper field of vision, and when you see it in the retina and in the optic nerve, it's represented below. and the temporal gets switched. It was here, it's on the T and N stand for temporal and nasal. So the temporal was on the lateral side here, but you see it moves on to the medial side. So everything really gets switched around. And finally you can see how when this temporal was the topmost, here you can see that it comes down to the bottom. So this is really showing you how vision is represented in the occipital cortex. Everything is upside down, and what the retinal image really is of an object, it is inverted and it's reversed from right to left. And that's why we say our eye is like a camera lens, because that's exactly what happens in a camera, in the lens, when we take a picture with a camera. Now let's move on to the next slide, and here talk a little bit about vision as we see in humans. One is, of course, that binocular vision is a cross sensation. You saw how it crossed first in space, so there was a crossing in space, and then once it came into the retina, you saw how the the nasal fibers, the medial fibers, crossed in the optic tract. Now the visual fields of both the eyes, they overlap, and you can see they overlap to about 2/3. So that's why you do not see two. If you're looking at an object, you see one of the object, and this part where there is no overlap, this is your peripheral vision. This third point we have here, only half of the visual information crosses, as the other half has crossed in space, and this is what I explained to you earlier. So only part of it crossed because the other half crossed up in space when it was going from right to left, up, right field to the left half of the retina. Now whenever you describe disturbances in visual pathways, they are always described from the patient's point of view. In other words, that what field of vision or what area of vision the patient has lost. You do not talk in terms of the retina. You do not say that the left half of the retina is lost or the right half of the retina. You will talk about left field of vision or temporal field of vision. Temporal means on the sides, which is this area, the temporal field of vision. Or you say the left half of the field of vision is lost, or the nasal field of vision. So you're talking about from the patient's point of view. That means in terms of visual fields and not in terms of which part of the retina is not getting impulses. Now let's look at reflexes, and this is important, and you need to know these reflexes. You must know what is the afferent limb and what is the efferent limb, and because you've done the midbrain and you've done the cranial nerves, it should get a little easy for you. So let's look at this pupillary light reflex, and we begin with light having struck the retina, and it travels through the stimulates the ganglion cells, travels through the axons of the optic nerve, and here they're just showing you the the nasal fibers which have crossed. You have the other fibers too. So this is the optic nerve, and this is the tract where you'll have fibers from the lateral part also going this way. So these fibers then go in the optic tract, and if you remember, in the optic tract 10% went in the medial limb and the other 90% went in the lateral geniculate body. So this is where these are the fibers which will go in the lateral geniculate body, and from here they form what is called the optic radiation, which goes to the occipital cortex. Now here we are going to concentrate on this 10%. So these 10% of the fibers, they go and they synapse in a nucleus which is present in the midbrain called the pretectal nucleus, and it lies in front of the superior colliculus, anterior to it. From each pretectal nucleus, fibers go to the parasympathetic nuclei of both sides. So it goes to the third nerve, the parasympathetic nucleus, which is the Edinger-Westphal nucleus, related to the third nerve of both sides. And you can see it's going to this side, the ipsilateral. You can see it's going to the contralateral side. So in other words, it stimulates the Edinger-Westphal nuclei of both sides. And this is called the consensual light reflex. And if you remember, when we did the corneal reflex, we had a similar thing going on, where the seventh nerve nucleus of both sides was stimulated. So once it goes to the Edinger-Westphal and synapse is there, then fresh axons start from the Edinger-Westphal. They travel in the third cranial nerve, and you can see then these are going to be in both third cranial nerve of both sides. These are preganglionic fibers because this is where the parasympathetic fiber begins at the Edinger-Westphal nucleus. So these preganglionic fibers travel with the third cranial nerve, and they go and synapse in a ganglion called the ciliary ganglion, which is seen in the orbit, and you should have seen it in the orbit. They synapse there, and fresh neurons, which are the postganglionic neurons, so we'll call these postganglionic neurons. These postganglionic neurons travel in a bunch of nerves which are known as the short ciliary nerves, and they go and supply the sphincter of the iris called sphincter pupillae. So when the sphincter contracts, your pupil constricts. So to repeat the reflex again, light strikes your retina, it stimulates the retina. The fibers from the retina travel in the optic nerve. The nasal fibers cross and the temporal fibers remain on the same side and go in the optic tract. 10% of the fibers leave the tract and go and synapse in the pretectal nucleus. From the pretectal nucleus, you have impulses traveling to both Edinger-Westphal, which are parts of the parasympathetic nuclei associated with the third cranial nerve. So both Edinger-Westphal nuclei are stimulated. The fibers then travel with the third cranial nerve, and they go and synapse in the ciliary ganglion. Now, to get to the ciliary ganglion, since they are traveling in the third cranial nerve, there's a branch of the third which goes to the inferior oblique muscle. So it's through that branch that they happen to reach the ciliary ganglion, where they synapse. So these are preganglionic fibers. Postganglion, because it's after the ganglion, postganglionic fibers begin from the ciliary ganglion, travel as short ciliary nerves, and they go and supply the sphincter pupillae. And here, if you're looking, you can see this is the iris. This area here is the iris. This is the lens, and this ligament here is the suspensory ligament. Now, in the iris, you have three muscles. You have a ciliaris muscle or ciliary muscle. You have a dilator pupillae, which is under sympathetic control, and you have a sphincter pupillae, which is under parasympathetic control. And you can remember, parasympathetic is for sphincter. So sympathetic and sphincter don't go together. It's parasympathetic for sphincter pupillae. So once the sphincter pupillae constricts, the pupil narrows. So that this is the light reflex. When you shine a light on someone's eye, the pupil constricts, and this is the pathway that the entire nerve. This is the entire nerve pathway in order to make the pupil constrict. Let's look at the opposite, which is the pupillary dilation or dilatation reflex, where the sympathetic nervous, so here we have sympathetic nervous system involved, and here what you have is from the hypothalamus, you have impulses traveling down, and usually it's in response to dim light, or one is scared, then this hypothalamus gets stimulated because it has connections with the autonomic nervous system. So from the hypothalamus, fibers travel down, and they travel all the way down. These are those descending autonomic fibers. They come to the thoracic segments of the spinal cord, and in the thoracic region, if you remember, you had this lateral horn present. So they synapse there. So that is the sympathetic pathway which is present in that lateral horn. From there, preganglionic fibers travel. They pass out with the spinal nerves, and they enter the thoracic sympathetic chain ganglia. They travel up. They do not synapse, but they travel all the way up, and they go and synapse in the superior cervical ganglia. Postganglionic fibers from the superior cervical ganglion. So these which you are looking at, the brown, are postganglionic. So these are postganglionic. So these postganglionic fibers, they pass in a plexus which is present along the internal carotid artery. So here we have the internal carotid artery. So in a plexus around the internal carotid artery, they pass with it, and they pass through the cavernous sinus, and then they go right through the ciliary ganglion. So they are also related to the ciliary ganglion, but they don't synapse because they're already postganglionic. So they pass right through the ciliary ganglion, and then they go to the dilator pupillae and to a smooth muscle which is present in this levator palpebrae superioris. Which is why when any part of this pathway is damaged, the smooth muscle in levator palpebrae superioris no longer has a nerve supply, and hence it cannot elevate, and that's why the eyelid droops, and we call that ptosis, which is part of the Horner syndrome. Since the dilator pupillae is also knocked off at that point, the constrictor takes over, and it's more powerful. So that's why you have constriction of the pupil and ptosis of the eye in Horner syndrome, and that occurs when any part of this pathway is damaged. So this is the pupil dilatation or dilation reflex. Let's look at the accommodation reflex. And in the accommodation reflex, you have three things happening. First is you have the ciliaris muscle which contracts, and that relaxes the suspensory ligament. And let's go back to the previous picture up here. And here what happens is it's this ciliaris muscle which is made to contract. It is supplied by the parasympathetic fibers. So when it contracts, what happens is this suspensory ligament is relaxed. Normally this is tense because this is pulled. When this ciliaris muscle contracts, it kind of moves this way and relaxes the suspensory ligament. So your lens now can bulge out a little more. So this is where your lens is going to bulge out a little more. And when the lens bulges a little more, it has a higher refractive index, and that helps to bring your objects which are close, it helps to bring it into focus on the retina. And that part is known as accommodation. The second part of this reflex is you have pupillary constriction, so that when the pupil constricts, all your peripheral light is, does not interfere with your vision. So that does not pass through the pupil. So it makes sure that only light passes through a narrow point in order to focus on something. So that's the second part. So there's pupillary constriction. And the third is both your eyes look medially. So let's go back here to this slide, and here what you have is if both your eyes are looking medially. So if you look at a distant object and then look at something close to your face, you will see that your eyes, both the pupils are medially placed. They are constricted, so your pupils are constricted. And this you can't see, the lens bulges in order to increase the refractive index and focus the light close to, on that point on the retina, the fovea. Let's look at the pathway in this. Normally when light strikes the eye and it passes in the optic nerve, passes in the optic tract, and you have pupillary constriction, at that time your fibers, if you remember, we just did this a little while ago, they pass through this medial route, enter the pretectal nucleus, which synapses on both Edinger-Westphal nuclei, and then that travels through the third nerve, goes to the ciliary ganglion, goes to the constrictor pupillae or sphincter pupillae, and the sphincter constricts. So that was a regular reflex. But in the accommodation reflex, those three things, they take a different pathway. The first is that when light shines on the eye, it travels in the optic nerve, passes through the optic tract, it goes to the lateral geniculate body, from where it passes on to the occipital cortex. So this is your regular visual pathway. So that means the occipital cortex realizes that some light has fallen on the eye. From the occipital cortex, fibers then pass all the way up to the frontal cortex, and they pass to an area in the frontal cortex called the frontal eye field. From the frontal eye field, now fibers travel and they approach the midbrain. So they come down to the midbrain, And in the midbrain, what they do is they synapse on the third nerve nucleus as well as they synapse on the Edinger-Westphal nucleus. So they synapse in this parasympathetic nucleus, which is the Edinger-Westphal nucleus, and they also synapse on the third nerve nucleus, which is this one, the main oculomotor nucleus. So from the Edinger-Westphal nucleus, the preganglionic fibers will start. They go to the ciliary ganglion, and then they go to the sphincter pupillae and the ciliaris muscle. So they make the ciliaris contract and they make the sphincter pupillae contract. So they take care of the lens bulging and they cause constriction of the pupil. By synapsing on the third nerve nucleus, the motor nucleus of the third nerve, fibers pass with that and they go to the medial rectus of the eye. When both medial recti contract, obviously the eyeballs are going to look medially. Now the difference you will notice here is there is constriction of the pupil, but in a regular pupillary reflex, the constriction occurred because fibers went first to the pretectal, which then stimulated the Edinger-Westphal. In accommodation, you can see that the Edinger-Westphal does not need the pretectal to stimulate it. Instead, it gets stimulated directly from the frontal lobe like this. So you see it bypasses this pretectal nucleus in this accommodation. Now this is important to remember because when we have a condition called Argyll-Robertson pupil, you have this pretectal nucleus which is knocked off. And when this is knocked off, if you shine a light on the person's eye, then you will see that the pupil will not constrict at that time because the pretectal nucleus is damaged. But if a person was looking at a distant object and then looked at something close by, the accommodation reflex occurs and you can see pupillary constriction at that time because the pathway is different, and that's because it comes from the frontal cortex. So this is the accommodation reflex. Let's look at some clinical conditions which are associated with the eye. First is papilledema, and we have discussed this earlier. And you know that the optic nerve is surrounded by this subarachnoid space which bathes the optic nerve as well as these blood vessels which pass through to enter the optic nerve. Now if there's raised intracranial pressure and there's increased cerebrospinal fluid, so you can see how that now increase is transmitted along the optic nerve, and because it presses on the optic nerve and it also presses on this retinal veins which are coming out of the optic nerve to pass out like this. So you can see that they get swollen, and this increased pressure also makes this optic disc bulge. So can you see this over here? So this area is bulging, whereas here you can see that it is flat. So when you look at the eyeball through an ophthalmoscope, this is what a normal eyeball would look at, a normal retina. You can see this is the optic disc, a clear area. You can see the blood vessels radiating and they are, nice and clear. In this case of papilledema, you see how the disc is not clear. You notice also that these blood vessels are not clear and they're quite swollen. This picture is rather small, but otherwise normally you can see that this optic disc looks extremely fuzzy. It's not clear like you see up here. And usually in cases of raised intracranial tension, before you do anything, all you need to do is look into the eyeball to see if you can check whether the optic disc is clear or not. And that's a good indication whether the intracranial pressure is raised. So that's one of the signs that we look for whenever there is raised intracranial pressure. Now here we're looking at some of the lesions of the visual pathways, and again let's start with the basic one, is if the optic nerve is partially damaged. So let's say that we are looking at this one. This is the right optic nerve, and it could be anywhere, and here they've put the lesion right in the middle. So if the middle portion of the optic nerve is damaged, then on this side it's the central field of vision which will go, because that's the macular area. If the entire optic nerve is damaged, you can see here, that means no impulses from this eye will pass through. So hence you cannot see from this eye. It loses both fields of vision, so this eye is blind. Now the third one, if the optic chiasma is damaged, if over here, as you can see, and actually this really should be, because they've kind of tried to show only partly, so just take a half like this. If this optic chiasma is damaged, you can see these fibers are damaged, this nasal half here and the nasal half here. And what does the nasal half get its impulses from, in this case, the left field of vision on this side, and in this case the right field of vision, which you can see the bitemporal. So it's known as hemianopia, means loss of half the field of vision, and bitemporal because both temporal sides are gone, and otherwise you can say left and right for this eye. So you can see how this is the left field of vision and this is the right for this eye, and if described in terms of temporal and nasal, you can see that both temporal fields of vision are gone. In the fourth, if the optic tract is damaged, remember this is the right optic tract, this is going to carry fibers which are responsible for left field of vision, and it's responsible for fibers which is again here. If you look here, left field of vision. So if you look for both eyes, you're losing your left field of vision. So you can see here in both eyes the left field of vision is gone because it's carrying fibers for left field of vision from both eyes. So your entire left field of vision for the patient is gone. So they can't see anything on the left side. If number 5, so that this is called homonymous hemianopia. Homonymous means the same field of vision. So here we are saying the left field of vision, so that's why it's called homonymous. In the upper one, it was left on one side, right on the other, so we would call it heteronymous. The Mayer's loop, actually you can leave this one out. This is just that some fibers of this optic tract, they kind of take a deep bend into the temporal lobe, and this is responsible for the upper half of field of vision. So if this is cut, you can see the upper half of the field of vision on both sides. On the left side is gone. So you can ignore this one. Let's look at 6, which is the optic radiation. This is very similar to this one. So you can see that the left field of vision is gone in both cases. If the optic tract, the visual cortex goes, again it will be the same thing. And here, as I told you, that the central field of vision is represented at the occipital poles. So imagine both occipital poles were damaged, then you would have central field of vision which is known as scotoma. Scotoma is a patchy loss of vision. So you can see that central field of vision for both eyes has gone. So this is pretty mathematical, so you can draw these figures and see, or if you get a question, you will get an image like this showing you one part is gone, and you can just work out which field of vision would be lost. Now here are other visual lesions we talk of, and let's look at the Argyll-Robertson's pupil. And so when you look at the Argyll-Robertson's pupil, one good way to remember is accommodation, reflex, present. So Argyll-Robertson's pupil. In Argyll-Robertson's pupil, the accommodation reflex is present. The pupillary light reflex, the light reflex is lost. So this is lost. So let's look at, again, let's just briefly review light reflex. And let me say that here is the superior, this is the pretectal nucleus. I'm going to draw this. This is the pretectal nucleus. And let me use a different color. This is the Edinger-Westphal nuclei of both sides. and this is the motor nucleus of the third nerve. So let's just do it this way. So here we have traveling, crossing in the optic chiasma, going into the optic tract, and let's say from this side. And I'm just going to use the same color, crossing over, going to this side. Here. Now in the light reflex, what would happen is that, let me use a different color. Part of these fibers would cross over, they would synapse in the pretectal nuclei. From the pretectal, it would go to the Edinger-Westphal of both sides. From the Edinger-Westphal, it would go with the third nerve of both sides, synapse in the ciliary ganglion, and then postganglionic fibers travel in the short ciliary nerves, and they will go to the sphincter pupillae. So they will go to the sphincter pupillae. So this was the ordinary light reflex. Now in Argyll-Robertson's pupil, it is this pretectal nucleus which is damaged. So hence, as the light comes here, if this pretectal nucleus is damaged, and this one too, because this is usually seen in syphilis, so usually tends to damage both pretectal nuclei, may damage only one. In any case, so let's say this one is damaged, so you shine a light on this eye, you can see that the fibers will not go to both Edinger-Westphal nuclei, and hence the sphincter pupillae will not constrict, so your light reflex is lost. But in accommodation reflex, the pathway is different. And here what happens is that as these fibers are traveling this way, so the fibers travel all the way to the occipital cortex, and they synapse in the occipital cortex. From the occipital cortex, the fibers go to the frontal cortex in an area called the frontal eye field. So they synapse in the frontal eye field. From the frontal eye field, fibers travel and they go to the Edinger-Westphal nucleus. Actually, both eyes get stimulated. So let's go here too. So that this goes this way. It goes to the frontal eye field. From the frontal eye field, now fibers will come and synapse on the Edinger-Westphal. So you can see how this pretectal nucleus is bypassed. From the Edinger-Westphal nucleus, the fibers now will, let me just use another color. So from the Edinger-Westphal nucleus, fibers go to the ciliary ganglion, postganglionic fibers they go to sphincter pupillae, and they go to the ciliaris muscle. So again, they go to the sphincter pupillae and they go to the ciliaris muscle. So you can see that the sphincter will constrict. So you'll have constriction of pupil when somebody looks at something far. Someone looks at something far away and then looks at something close by. That sets off this impulse. It travels all the way like this to the occipital cortex, frontal cortex, to Edinger-Westphal, ciliary ganglion, sphincter pupillae, and ciliaris, so the pupils constrict. And at the same time, these fibers which have gone here, they also stimulate the third nerve nucleus. So the fibers stimulate the third nerve nucleus. From here they pass to the eye. So they pass to the medial rectus of the eye. So let me bring it this side. And the medial rectus pulls the eyes medially. So that's how you have both eyes looking medially. You have constriction of the pupil, And you have accommodation, which means that when you look at a distant object and then look at a closer object, the eyes get to focus better because the lens bulges. So you can see that in Argyll-Robertson's pupil, the accommodation reflex persists or is present, but the light reflex is lost. Horner's syndrome. In Horner's syndrome, as I mentioned earlier, it could be anywhere. The lesion could be anywhere where in this whole autonomic pathway. So it could be from the hypothalamus, the tracks going to the lateral horn of the spinal cord. You could have so that lesion could be in the medulla or the pons, or if there's a cervical lymph node enlargement, that could press on the superior cervical ganglion. Or as this is passing through the internal carotid artery close to and going out, there could be a pressure somewhere there. So in all of these, as I mentioned earlier, in this case, your dilator pupillae is affected. So the pupil is constricted because the parasympathetic now is overactive, and because that smooth muscle called Mueller's muscle, it's called the Mueller's muscle in the levator palpebrae superioris, that part is gone. So the elevation of the eyelid is not good. Instead it droops, so you have ptosis. So that is Horner's syndrome. Now in brainstem injuries, if you look at this in the actual PowerPoint, you'll see that this is not reactive. In brainstem injuries, because it is the parasympathetic part which is damaged in the third nerve, these parasympathetic fibers are present along the superficial part of the third nerve, that means on the outer side. So they are the ones which are first damaged in any brainstem injury. So because the parasympathetic system is involved, now the sympathetic system becomes overactive. So it's the opposite of Horner's syndrome. So what happens is that the pupil on that side is dilated and it doesn't react to light. So that's why we say it's fixed and dilated. So this is what you're seeing, and if you look at the PowerPoint, you can see that this will not show any reaction, whereas this one will constrict and dilate because this is a normal pupil. So that finishes this presentation, and look at this presentation again and draw these diagrams yourself, so that will help you understand the pathway better.